invite Stu Goldstein, Jean-Maxime Coté to join here at the podium. And theoretically, I should have invited also Pat Murray, but he's late.
His flight is delayed, so he sends his condolences.
Oh, okay. But he is still coming to Vicenza?
He's still coming to Vicenza, yes.
Okay. So please have a seat. I was kindly invited to choose the modality by BIOPORTO on how to manage this MIDI expert. So I decided not to use slides, but rather to hear about your experience. And because the topic is how to move biomarkers into clinical use, apparently you both had a positive experience in your hospital, in your institution. So I would like to start hearing from you, how was the pathway to routine adoption of biomarker? We can start with Stu.
Sure. Thanks, Claudio, and thanks to BioPorto. So I think for us, the motivation was, we all know that AKI is bad. We've been coming to meetings like this for 20 years, and the epidemiology is really clear. And functional markers like urine output and creatinine, which are all important, are too late. And lots of work has clearly been done, and I've heard at the biomarker session yesterday, people were saying, yeah, how do we put these into clinical use? Everyone believes these biomarkers tell us what they're going, that the kidney is injured in some part of the tubule or through stress, etc. The question is, how do you make that helpful to the clinician at the bedside? And how do I make that as a nephrologist beneficial to the intensivist? And if I go in and I say every single patient who comes to the ICU, NGAL is the biomarker we have on our clinical platform, needs an NGAL, then first of all, the performance is not going to do well, and no one is going to accept it. So what we did was to really recapitulate the acute coronary syndrome paradigm, and Mink Chawla and I developed this concept called renal angina to basically use simple population metrics to tell you who is not going to get acute kidney injury. And that metric in the renal angina index isn't really great in predicting who will. But then we add a biomarker to that risk stratification system, and that biomarker will improve the predictive performance. And once we motivated people that way, then and we did some pilot work, some manual work, people started to see its potential benefit.
Yeah, we had the same kind of pathway in our institution. We started with a predictive model for 1 year. Then we used biomarker and see how the predictive model was upgrading, let's say, especially for the negative predicted value, which is very important. There is no point to predict raining when it is already raining, right? And if it is a perfectly sunshine day, you may not need the umbrella, but it's when the uncertainty is present that you want to work about this. And then finally, we use the biomarkers for intervention.
Yes.
Which is basically how the workflow in your system works. But this will be the next question. I want to hear about your institution.
Yeah, it's kind of different. In fact, I worked with Pat Murray when I was a fellow there, and I'm kind of an early adopter of AKI biomarkers, I guess. And I helped him to just try the biomarkers as a diagnostic tool to help for the differential diagnosis. So not to prevent AKI or not to identify patient at risk, but either to just try to help the clinician to identify, is it more a prerenal or more an intrinsic AKI at the bedside. So when a clinician in real life, a nephrologist saw a new consultation, it's not clear. It's a weird case. It's kind of, it can be prerenal, it can be intrarenal. It's not clear. So we implement the NGAL for that specific kind of patient. So we start first at the St. Vincent's University Hospital in Dublin when I was a fellow there. And I think the need for training to clinician is really important because not everyone is expert with biomarkers. And it took some time to them to use it more useful with more usefulness, I guess. So we did that in Dublin 2 years ago, and back on that experience, we saw that it was really relevant, especially in patients that it wasn't clear if we had to continue the IV hydration because the patient is the hemodynamic stability is okay, is stable, and he had a probable ATN. So should we just stop the fluid repression? So we order an NGAL. NGAL is really high, so we just stop the fluid at that time. So it can prevent some unnecessary fluid accumulation. And it was especially appreciated, I think, by the team of hepatology, especially if there's not a clear hepatorenal syndrome, and they want to know if it's more like a physiology compatible with that. So, of course, a high creatinine with low NGAL, low FeNA. So it comforts the clinician about the diagnosis. It can help to make the management more quickly. So that's how we use it in Dublin. So when I came back in Montreal, I did the same thing. So I implement the NGAL in my own hospital, and I did the training since the beginning. So I explained to them, you need to have the right question for the patient to be able to analyze the NGAL, because it's not a perfect biomarker. We all know that. There's a lot of limitation to them, especially in patients with UTI, if you use the urinary biomarkers. So in Montreal, we have a panel. So when you order NGAL, you have a urine panel that includes dipstick, urine culture, proteinuria, albuminuria, urine sodium. So you can have in front of you, when you order the NGAL, all the information you need to see if the result is a false positive or a true positive. So it really helped clinicians to do that. And in Montreal, despite that the nephrology team was really helping and finding the test useful, the hepatology team as well and the oncology team use it. Especially because if they had a patient with a slight increase in the creatinine, it's not sure it's just dehydration or a toxic effect of the chemo that you just received a couple of days before. So it can help us, help them and help us to make sure about the diagnosis. So it wasn't to prevent anything. It was more to optimize the process of care on patients with an already confirmed AKI.
I have a personal question for you. Did you ever take care of any member of the hockey Canadian team with trauma and acute kidney injury?
No, it's not a trauma hospital, so no hockey player in my hospital.
For those who don't know, I'm very passionate about ice hockey. So, Stu, how did you change your practice? How did you train your personnel to deal with biomarkers?
So the other component was really to give people the information that they needed at the bedside in near real time. So we worked with an initial internal funding from the hospital to develop an electronic health alert that comes straight into our electronic health system called EPIC. And at 12 hours, the renal angina index is automatically calculated and resulted in EPIC. And it comes up on the first page of the result tab. Not only is it on the first page of the result tab, the resident, when she or he is presenting, the renal angina index number comes up, so they have to discuss it on rounds. So this is all Cincinnati Children's process improvement. And if the renal angina index is 8 or greater, that tells you the patient is at higher risk. An NGAL is automatically ordered in the electronic health record. No student, nurse, resident has to order it. It's reflexively ordered. So we absolutely take all of the manual process out and give people information at the bedside. And after a year of doing that, very similar to what you saw, and these data will be published very soon in Kidney International Reports. Again, the negative predictive value of the RAI was 98%. The AUC was 0.88, but again, it was all negative predictive value. The positive predictive value was terrible, but that's okay. If you're going to give a drug for a chemotherapeutic that's $1 million, you want the positive predictive value to be really good. If you want to rule out a bunch of patients who are not at risk, you want your negative predictive value to be very good. And what we saw when we added NGAL to the RAI positive patients, we even improved, as you've said, the negative predictive value, but we doubled the positive predictive value. And then that now and I know it'll be in another question, but we then said, now you have this information, how are we going to use that for clinical decision support?
So I told you the Americans love numbers, right? But in fact, there is a little bit more. It's important to have the team that is used to the biomarkers, that know the value of the biomarker, in order to order the biomarker at the right moment, as you mentioned. But you might be aware of our experience of the nephrology rapid response team. There is no point to order an urgent test and then have the test sitting in the lab or on the desk of somebody. How did you implement the immediate information? Did you do?
Yes, we did. So we make sure that we use the right analyzer for that test. So when we order the panel, especially for urine NGAL, it's quite quick. So I think the median time between the initial order, it's still paper in our hospital, the initial order is 2.9 hours between the order and the result on our EMR. So it's kind of quick. It's the same time as a FINA, so it's not that bad at the end to have the result of the NGAL. It's easy to implement the NGAL. It's an easy platform to use with most analyzers. So yeah.
And it is interesting that when you use these biomarkers, the more you use, the more you find application and you learn how to interpret. For example, believe it or not, we use NGAL in the PD fluid to make an early diagnosis of peritonitis, for example.
Yeah, and I also want to respond to your observation, which was really important in terms of urinary tract infection, which NGAL is very high. However, for pediatrics, we take care of many patients with congenital anomalies of the kidney and urinary tract, who they have to undergo daily or 3 times daily catheterization to empty their bladder. And they often have white cells, pyuria in the urine. And then patients get prescribed antibiotics. We select out, and then we get resistant organisms, so we're going to have to use a Seraph in these kids to get them. But now the urologists order NGAL in your outpatient urology clinic, and if the NGAL level is less than 150, they don't treat with antibiotics, and so we are not pressuring the ecosystem to select for resistant organisms. So very similar to what you're talking about.
There is a learning curve.
Yes.
The more you use it, the more you use it. So, and my view is that the more you use it, and the prices will go down if you use it more, because it will become a routine test in the future. Now, very quickly, how successful was this program of application? What was the impact on your general practice? And if you have to advise somebody in this room to start this process, what would your recommendation?
Sure.
We hear you.
Sure. So in our study, taking focus 2, when a patient is RAI positive and NGAL is greater than 150, the patient gets a standardized dose of furosemide, so the furosemide stress test. And if they do not respond, and the patient gets to greater than 10 to 15% fluid overload, which we know is associated with poor outcomes, the recommendation is to start renal replacement therapy. Because remember now, we've ruled out 98% of the patients in the pediatric ICU. Now, we did not mandate that, Claudio, but we recommended that. And our results, which we presented in San Diego and we're about to submit, we showed patients started CRT a day and a half earlier. And if you talk to the intensivists, they say, yeah, we would think we would have put these patients on CRT anyway. Maybe we started about a day or a day and a half earlier. That was true. And you thought, okay, they're starting CRT earlier, so they're going to be on CRT longer. No. They were on CRT for 2 days less. They were extubated 5 days earlier, and they were out of the ICU 8 days earlier. And when we looked at our percentage of patients who were greater than 20% fluid overloaded at the start of CRT, that went down from 40% to 20%. And when we looked at survival for patients to leave the ICU who received CRT increased from 40% to 60%.
So, given these results, and given we have Peter in the room, how was your relationship with the administrator of the hospital? What were the objections? What were the problems? We had problems.
We had to. So I don't know in the US, but in Canada, as you know, it's public healthcare. So for new biomarkers to be reimbursed, in my province at least, in Quebec, you have to make sure that they want them to reimburse, and you have to prove that it's required. If it's a really high price, of course, the need for more data is higher. If it's a really low price, you don't really need to do nothing. So the plan was to do a 1-year implementation phase in our hospital, which is the biggest center in the province. And based on these data, we can apply for a national coverage of the NGAL for the entire province. So that's the plan. We're still on that. So we had the test that has been covered for 1 year and a half. Now we had like two months that is off, but we will restart to use the NGAL again. And the plan is to have results on that in the next few months.
One last quick question. How would you see the future? Let's imagine a patient or parents of a patient that develop AKI. Would it be imaginable that he or she come to you and say, why didn't you do the biomarker? You understand what I mean? In other words, from one side we have the administrator saying, oh, you have to show the evidence, but there is a level of evidence that some patients may say, well, for me it's enough. Mm-hmm. If you have done this biomarker, probably you would have diagnosed this 24 hours earlier. Would have this changed the practice? So how do you see this scenario for the future?
Well, again, I think it all comes down to risk stratification, Claudio. If you go in and even to the administration say, I want to get a biomarker in every single patient, then it's not going to work as well, and the administration won't want to pay for it. And same thing for parents, to say, look, your child's at very low risk. Now, that doesn't mean we say, you will not get this biomarker. This is just a risk stratification tool, and then we have to be clinicians. And if there's something about the patient, they previously had AKI, they're a bone marrow transplant patient, and something else happens to them, then yes, we'll get the biomarker to help us, just like to adjudicate structural versus functional AKI. But when you show them that with risk stratification, only 1% of renal angina negative patients get stage 2 AKI, whereas 35% of RAI positive patients get AKI, they understand that. And I think that's what we can tell them. The other thing that's been very helpful in terms of a cost-saving measure the way we first started to see its real benefit was in renal recovery and making the decision, am I going to dialyze this patient today or not? And when we start to see the NGAL really coming down, we can talk to our cardiology colleagues or our intensive care colleagues. I think we can hold off. Let's see what happens to urine output and recovery here. And so people get very comfortable with it in that way.
But here we have, Jean-Maxime, you lived two different realities, right? And you are living another reality and I'm living another reality. I think from my side, the easiest way to solve all this problem of would be, I'm director of a division of nephrologists. Okay, I have a budget. Let me manage the budget. Don't question whether I use the Seraph, I use the biomarker. Judge my results. The cost benefit of the entire renal division. Don't come to condition my choices. And this is something that administrators don't like to do, because when you save money, it's their merit. When you spend too much, it's your fault. So I hate administrators.
Right.
Anyway, thank you very much for today. Thank you to BioPorto for giving us the opportunity to present this important experience. And remember, Jean-Maxime and Stu will be available also in the corridor in the future for personal talk.